Pakwesi, all the best. Why?
Yeah, thank you.
We are eager to listen to the all the good filler.
Yes, Mrs. Wife. Mrs. Wife, sisters are supporting you here.
Okay.
Yes.
Thank you all for joining and joining on time as well. So this is the first time I think we've started right on time. So thank you all for joining. I'd like to introduce our speaker. I think we all know him, but in the interest of good process and formality, I'll just introduce him briefly. Before Norris came to Motown, he went to a preparatory school called Dex in Tema. At Motown, he completed the O-level certificate with us in 1993. And then he went on to SOS HDIC in Tema to do his IB program. He then went on to University of Ghana and University of Ghana Medical School, where he completed a BSc in Medical Science in 1999, and then MB-CHP, the Bachelor of Medicine and Surgery, in 2003. That was the class of 2002. He completed his housemanship at the Department of Medicine and Therapeutics and Obstetrics and Gynecology at Kolebu Teaching Hospital. Norris, next time, please use fewer big words so that I can go through them very quickly. And then he worked in the private sector at Tema Port Clinic at Tema Community 1, if you've ever been to Tema. Then he went to the US to pursue further studies and got his educational certificates for foreign medical graduates. And he did internal medicine residency at Cleveland Clinic's hospitals in Ohio, United States. That was between 2007 and 2010. And he worked as an internist hospitalist at Further Care Regional Medical Center in Appleton, Wisconsin, between 2010 and 2015. And then at the Ascension St. Elizabeth Hospital, also in Wisconsin. That's where he's been working since 2015. He's a member of the American College of Physicians. He's been a member since 2011. He's a board certified doctor on the American Board of Internal Medicine, and he's been a member since 2010. He's happily married to Mamiya, Dr. Mamiya Bosio Norman Nipoku, and they have 3 boys. He lives in Wisconsin, United States. And Norris is able to, when he is able to eat and drink and breathe soccer, he likes watching Liverpool. I think this year has not been good for him, so we can cut him some slack on that one. And all kinds of sporting activities. He likes to travel with his family as well, but he is not able to pack. So at the moment, he's looking for somebody who can do his packing for him before traveling. I believe Mamiya is busy doing the packing for the 3 other boys, and Norris is probably the next one to be on the line. So if you can help him out with his packing, please let him know after this. So hand over to Norris. Norris, over to you. And we thank you for accepting this talk and preparing for it. Thank you so much. Over to you. You'll mute yourself.
Thank you, Christopher, for the introduction. I've known Christopher for a long time, since preparatory school. So it's been a while. All right, so let's start. So basically, I mean, it was a good idea. One of our colleagues, Soji and Christopher, thought as a physicians cannot stand by. We should be able to share as much as we can with our colleagues about various things that we think we should know about to continue to improve our health, so that with our 50th anniversary, 75th year anniversary, we can all be healthy enough to attend them and continue to enjoy each other's company. So I opted to talk about kidney disease. For one, I'm an internist, meaning those in Ghana, what we generally call physician specialists. Colleagues of mine have subspecialized and they are what we call nephrologists. They deal with kidney disease and hypertension as well. I'm not a nephrologist, but like I said, for internal medicine, we deal with all these. The subspecialists pick up some of the various plenty things that we unfortunately have to know and tend to specialize on them. So just so you know my background. But chronic kidney disease is something that unfortunately I do see a lot of in my line of work. And you may think it's just in Ghana, but in the so-called developed world here in the United States, you have patients even coming in not knowing that they have chronic kidney disease. And I'll cut the primary care physicians some slack. It's not to say they do not involve their patients in decision making, but this is a kind of disease where it could be problematic for you or not, in the sense that one can have it, and as we talk, you know about the various stages of the disease. One can have the disease and either not know it, it may not bother them. They might be at a standstill at a certain stage of the disease for a long time till, God calls them off the earth. Others will have a very fast course of the disease, where the disease progressively gets worse to the point where they may need what we call dialysis, which a number of us have probably heard of. So the whole idea is to bring us to, to the point where we will know about this disease and we'll be empowered to talk to our physicians about this, and we'll advocate for ourselves in terms of screening and, essentially taking care of us. Preventing ourselves from having this. There are things we do day to day that will certainly put us at risk of this illness. There are certain things that we may be doing and would not know. So let's go ahead. And basically, this is a discussion. I'm a talkative. Chris Mo will tell you from Dirty Poetry, I've always found myself in trouble. Others think I don't talk much, but I am. So I will find myself sometimes talking too much, and I'll try not to. I want this to be a discussion. As you can see on my first slide, it's a discussion led by me. And generally, if you want to ask a question, you can. If you want to wait and ask, that's fine as well. So I'll move on to the next slide. So basically, this is a general snapshot of our colleague Mamea, pushed me to put this slide in, because he said, don't make an assumption that everybody knows where their kidneys are. Everybody knows what kidneys do in our bodies. I shouldn't make any assumptions. So I thought that was a very good idea from her. But basically, our kidneys are, to put it simply, our body's filtration organs. I'm trying to move this. Yeah. Our body's filtration organs, they essentially filter our blood of all the toxins and, excessive insults we put in our bodies. They do get rid of them through our urine. Our GI tract does other aspects of this kind of elimination process, but the kidneys do the filtration of our blood, take out all these toxins. Sometimes you can have an antibiotic, and when you pee, you can smell it and things like that. It's all part of the elimination process from the body. So those are the things that kidneys do. The good Lord in his wisdom gave us 2 kidneys, and they've been extremely important. People can live off 1 kidney. Some people are born with just 1 fully developed kidney. They still survive and have a fairly normal life. When you hear about kidney transplants, we never transplant all 2 kidneys. It's never the case. It's just 1 that we put in, and it works fair enough. So 2, I'll say, is a luxury, and it's important that we take good care of them. So as you see my screen here, this is basically a scheme of the human body. Just a minute, I'm not sure if my mouse is working, but maybe or not. But as you see on my right, as we look at the screen, you see one slightly higher than the other. It's not a mistake. It's usually the left one which is higher, because the right one right above it is where our liver is, which is a fairly big organ. So it naturally, pushes the right one a bit lower. When you do a liver ultrasound for various reasons, and an ultrasound tech or a radiologist can still see your right kidney and may find some diseases there and all that. So the right one is a bit lower by design, to make room for the liver above. The ureters are basically the tubes that drain the kidneys and bring our urine to the bladder. Our bladder is there, very important organ. It's basically a storage organ. It stores our urine. When it fills up, you get the urge to urinate, and then you pee your urine out. So like I mentioned, as a storage organ, sometimes folks can have various illnesses, be it bladder cancer, things like that, where they might even lose their bladder. And over here, a bladder can be created sometimes using other people's intestines for them to store urine. They have a tube leading out from their abdomen, emptying their bladder and all that. So in as much as it's important for, again, the good works of our good Lord, whatever beliefs others believe in. I have colleagues who think we all evolved. They don't believe in creation, but whatever the case might be, this was made to store urine, for this to be emptied when we can have the urge. These ureters that you see, again, little tubes leading from the kidneys, sometimes they can get blocked by tiny stones. It might give you the worst pain you've ever had. I don't know, maybe the ladies will say contractions during pregnancy will be the worst, but this kind of condition can be extremely painful. Kidney stones you will hear of. And recently I had a patient who had, for whatever reason, we scanned his liver and we saw this huge, kidney. One of them, I think, was on his right side. Like I said, the liver, when you do scan, you see the right kidney. His kidney was so large, he never felt any pain. He was extremely surprised. We talked about his kidneys being enlarged and all that. I spoke to one of our urologists, which again, I mentioned nephrologists earlier. Urologists are surgeons who are specialized in kidney problems. So they are what we call urologists. And I speak to a urologist and we got some CT scans, and lo and behold, the guy had a stone in his ureter. He never felt pain. And this kidney was massively swollen, such that, again, he was functioning normal, because again, the good Lord gave us two kidneys. The left one all this while was handling his urination and filtration business, and he was living like a normal life. And this guy did not come to the hospital because of this. It was for a totally different thing. So again, they are important. You do not want them to be diseased, otherwise they could give you big time problems. So that is basically a general scheme of the normal function of our kidneys and what our kidneys do. The more enlarged picture on the right, again, shows a cross section of the left kidney. It shows what we call the renal pelvis, and various aspects of the kidneys. I'm not here to bore us with, anatomical stuff. It's not going to be the purpose of this, but basically just to show us what we have in our bodies. You'll see the aorta, which is the biggest artery in our body, the inferior vena cava, the biggest vein, which drains our body, and things like that. So we'll move on to the next slide. So next one is basically a microscopic unit of a very important aspect of our kidneys. It's called a glomerulus. We have millions of them in our kidneys, and they do an extremely important work. I'm bringing this in because I'll be using a certain terminology as we go along, something that I think everybody shouldn't be a physician to know. One thing I have really enjoyed in my practice here, and something that, again, not to slight my colleagues back home, we don't do very well, is to involve patients in decision making. is something I pride myself in, because I can tell you that if from experience, if a patient knows exactly what is wrong with them, you get the most compliance from them in terms of them taking their medications and them understanding what is going on. So, you know, we all have our fields of work. There's nothing wrong with sharing with people what you think may be complicated and whatnot. There are always ways you can break down things for anybody to be able to know, understand, empower themselves with. So you'll be hearing a terminology called GFR as we go along, and it's basically called glomerular filtration rate. And it's based on this glomerulus that I'm talking about. You know, this is basically, like I said, a scheme of it. Good, my mouse is back. This area that you see here is basically the glomerular capsule, which, as you see again, this is a very microscopic unit, but picture millions of these doing all this at the same time. They receive the urine. This is where a lot of the reabsorption and things take place. They will reabsorb some of your electrolytes. By that I mean your sodium, potassium, whatever your body needs, it will reabsorb back into the system. Will filter out the waste urine product, you know, back into the bigger ureter. You know, it doesn't work on the screen. Anyway, the bigger tube that I talked about leading into your bladder. So this is what they do. Now, when these units get diseased, that is the beginning of a problem, you know, that you develop as time goes on. So when we talk about GFR, we are talking about the glomerular filtration rate, how fast these things are able to work, how fast you're able to filter our blood and eventually bring out urine, take out the good substance that the body needs back into the system. You know, every tissue in the body has an artery and a vein in terms of blood supply for the viability of the tissue. So you see an artery here supplying in, and then a vein draining the what's it called, whatever tissue or capillary unit in the body. If you want to picture, how do I put it, an organism or an organism like us as human beings, you know, you can break us down to organs, down to tissues, down to cells and capillaries and things like that. So each unit works, you know, just with this same system. So veins, if you remember, they flow towards the heart. So they drain blood towards the heart. Arteries flow away from the heart. They supply our tissues. So they go in, they work, they take the oxygen and everything out. You know, the veins to take out the deoxygenated blood back to the heart, gets reoxygenated again with the help of the lungs back into the system and things like that. So that is why you see arteries and veins here as well. So basically, this is the filtration unit of the kidney. Next is what I'm trying to talk about today, called chronic kidney disease. So we call it that because it's essentially a chronic condition. We can have acute problems to the kidneys, which if picked up, we can do things to fix them back to normal kidney function. So when we talk about chronic kidney disease, it's essentially a time when the kidney structure or function, and I'll be talking perhaps more about function, but structure, like this guy that I'm talking about who came in with a very enlarged right kidney, you know, his kidney structure was abnormal. When you have an extremely enlarged kidney for a very long time, the kidneys may, you know, if you can picture a small area where tissues are supposed to live freely, if they get pushed against each other, that whole, what we call tamponade or pressure situation can cause some of the tissues to die off. So in as much as we were able to relieve his kidney function, take out the stone, likely the kidney over time gets back to normal structure and things like that. Over time, this kidney is probably not going to function well. So that in itself will be having a chronic kidney problem in there. When you have other diseases, which again, we'll get to know of as we go along, they can affect the kidney function over time. And the time period we tend to use is 3 months. When you have at least 3 months or more with these problems, then you go into the realm of chronic kidney disease. And these things should not just be there, but have implications for the health of the patient as well. So that would be a technical definition of somebody having developed chronic kidney disease. So move on to the next slide. So incidence of chronic kidney disease, again, in March, again, our good friend posted some slides. I don't know if some of us paid attention. So he posted some slides on kidney function way back in March on our page, and it was when World Kidney Day was being celebrated, and Ghana has a kidney foundation. And on some of those slides, they indicated that 13% of Ghanaians have chronic kidney disease, which is not too far off from the United States within adults greater than or equal to 20 years, where they do have where there are 14.8% of these individuals also having chronic kidney disease. So, not to talk about actual numbers, but in percentages, we fall in the realm of world incidental rate. So basically, we are no different so much from adults in the United States in terms of rates of kidney disease, but it's about what we're able to do for these things, in various countries and the like. So I'll go to the next slide. So what I talked about, if you recall, about the glomerulus, it is what we use to essentially stage the kidney disease that I talked about. So stage 1, as you can see, again, Mamea, the engineer, saw this and said, why do you call it a disease? Stage 1, you say the rate is 90% or greater. Why is it a disease? Because the rate is high, and it seems to be normal, but you're saying that it could be a stage 1 of a disease. We will say that because you can have a normal rate, 90 or greater, but at that time, there are certain things that we'll find specifically. Let's say you have a simple urine test, your physician will see blood microscopically in your urine, of course, reported by the lab. They may see some proteins in there. These are not normal. So when you see things like these, you have to be concerned, and it may be related to be it a problem from associated complication from diabetes, hypertension, things like that, even some undetected urinary tract infection, which may have involved the kidneys, showing these things in the urine. When you see that in combination with these illnesses, then you are at a stage 1, which is a very mild form. Mostly one can recover from. Stage 2. So again, let me make sense of these numbers. So the eGFR that we see in the leftmost column is estimated glomerular filtration rate. Now, 90 or greater, I said, is stage 1. Stage 2, between 60 and 89. These numbers are reported by the lab. When you go and you do what we call a chemistry panel, or what you may see, maybe they'll say, go and do your blood chemistry or your basic metabolic panel and things like that, your electrolytes, they'll report these numbers. They go in consonance with some blood work that you may have also seen in your lab work called creatinine, your creatinine level. So the calculation is based on, it's a very complex equation, which we are not going to be talking about, but it comes out with these numbers of the GFR, 90 or greater, like I said, in combination with blood in your urine, protein in your urine, puts you at the stage 1. When the rate goes between 60 and 89, it puts you at a stage 2. When it goes between 45 and 59, stage 3A. It used to be just stage 3, but they split it to 3 and 3B, because the stage 3 part is where you start becoming concerned. Nephrologists were saying that, well, again, nephrologists are kidney specialists, physicians like myself, but kidney specialists. They like to start seeing patients when you're at a stage 3. Of course, a lot of people go into stage 3. Some stay there for a very long time, do not progress, and they can live a normal life, of course, doing the right things to keep the kidney disease stable. And so they were seeing a large influx of stage 3 patients who were not moving anywhere. So I believe it was part of the reason why they had to split the 3A and 3B. I mean, the stage 3 into 3 and 3B, where now they are more concerned about 3B and below, or 3B and above, whichever way you look at it. So when you're 3B going to stage 4, stage 5, you have to really start seeing a nephrologist and start doing things differently, not just working with your physician specialist or your internist, but start seeing a nephrologist to help you arrest the progression of the illness, or to start doing things to basically get things better. So that is basically the staging of the kidney disease. It goes up to stage 4, stage 5, which is extremely severe. At that time, you're likely going to need to start dialysis, or you may need to have discussion about a kidney transplant. So this is basically the progression of the disease as you start, living with it. Now, in as much as I mentioned the numbers, we don't only wait to be alarmed sometimes about the absolute numbers of the GFR. When we see a greater than 25% decrease in your GFR from your baseline known GFR, again, when I talk about baseline, you may be having yearly physicals with your physician or every 6-month physical with your physician, where they'll be doing your blood work and things like that, and they'll be watching these numbers. When they start seeing, so if you look at the numbers, you could be within one stage, but then you have a 25% decrease. You may not have veered into another stage yet, but that decrease is always going to raise an alarm with your physician that there could be something wrong. What are you doing differently? What are you putting in your body causing this? Or per year, if you see that this number goes up greater than or equal to 5, so again, you can be within stage 3A, your GFR could be 45, and then suddenly it goes down to 40, or, it's 59, it goes down to 55, things like that, it should raise an alarm. And again, if you're empowered with this information, you compare your labs, you can ask your physician to maybe help you address these things. All right, we'll move on to the next slide. So these are risk factors associated with chronic kidney disease. The most common things are perhaps the first three: diabetes. This is the one illness I, in my opinion, is extremely dangerous for the well-being of any individual. Diabetes can affect you from head to toe, and it does a very big number on the kidneys. So when you're diabetic, please, you need to take extreme care of yourself, so as you don't develop conditions like chronic kidney disease and things like that. It's extremely important. Hypertension as well. That's a very big number of the kidneys. And like if you heard me in the beginning, I talked about nephrologists. They don't just deal with kidney disease, they deal with hypertension as well. If you are working with your physician, you have high blood pressure or hypertension and your numbers are not coming down, you need to see a nephrologist. That's their specialty. They can help your primary care physician or your family practitioner or your GP, bring your blood pressure down. And if you have a sustained increase in, blood pressure, apart from all the things it can cause, it can lead to chronic kidney disease as well. Toxins. Again, not to slight any traditionalist or our herbal folks or anything. The one problem that we in mainstream medicine have had with some of these herbal products is we don't know how much work has been done on them, in terms of safe dosage levels and things. You talk to them, you say, for cut back, for say, you don't know whether that amount you are taking at that one time is good for your kidneys or not. So these are things that go into medication preparation before medications are approved for general use. One very common medication that all of us take, some of us do not, what we call NSAIDs or non-steroidal anti-inflammatory drugs. Examples of them are ibuprofen. Common trade names are Brufen, Motrin, or we have naproxen or Aleve. Here in the United States, we have medication called diclofenac. These are all good medications, but if you overdo them, they can extremely damage your kidneys. And we have to be careful. So take them only when needed. You can always bounce between them and acetaminophen or Tylenol or paracetamol, and not overdo these things. Apart from the fact that you may have read on them, if you take them on an empty stomach, they can cause ulcers and things like that. We see a lot of these medications causing kidney disease. Especially, unfortunately, somebody with arthritis may be taking these medications for a long time. They don't do checkups, and then they go in one day, their GFR is at the stage 3A, stage 4, and things like that. So extremely important. Of course, just like, having a car, and over time, it's wearing, as we age, our organs also age. So just the mere fact that you are older will put you at a higher risk than a younger person in terms of developing kidney disease. Being obese or overweight, we are all every day trying to work on our weight, can also put you at risk. Unfortunately, we Blacks, have a higher risk of developing kidney disease. And it's just what it is. So they found a gene sometimes that can help express, or rather help in a negative way, express this, condition as well. So it's just what it is. Unfortunately, in Black communities here in the United States, you find a lot of them with kidney disease, a lot of them on dialysis. Unfortunately, that is also what we are blessed with. So it's all part of the reason why we need to be taking very good care of our kidneys. Such that I'll mention, if you get your blood results, sometimes take a look. You will see that there are different ranges of GFR for African Americans and then everybody else. African Americans or Africans or Blacks, our numbers are different. Our ranges of disease are different from the general population. In other words, we generally have a lower GFR to put us into disease range. So let's say somebody's 45 will be equal to our 39, that kind of thing, So that is what studies have shown, where we are able to handle lower GFRs better than the other population. So these are some of the things. I talked about obstruction, like the kidney stone of this other guy that I told you. That's what the obstructive uropathy basically describes. It can be from stones, it can be from tumors, whatever the case might be. All of that will put a what's it called? Risk of developing chronic kidney disease. Unfortunately, females tend to develop more chronic kidney disease than males. Good old alcohol, doing it excessively will put you at risk. Smoking, drug use, I'm talking about illicit drugs or street drugs, all of that will put you at risk of developing kidney disease. And our good old, again, unfortunately, in Black population, sickle cell disease or trait can also increase your risk of developing kidney disease. Next slide. One painful thing about chronic kidney disease is that, just like with a lot of dangerous problems in medicine, they show when you start developing symptoms specific to chronic kidney disease, is usually too late, where the disease has gotten so far. That is why it's extremely important. I cannot overemphasize that. All of us are at least 40 years, and even before then, it's extremely important that we have a general practitioner or a family practitioner or an internist or somebody we see yearly for yearly physicals, so that you check all these things on a yearly basis. Sometimes based on what you have, they can ask you to come in every 6 months and things like that. My younger sister is a nurse. She works in one of the polyclinics in Ghana, and she was talking to me about how she runs a wellness clinic, and I was extremely impressed, because these are not things that we've incorporated in our day-to-day lives as well, where we take care of ourselves. We only want to see a physician when we are ill, but body maintenance is extremely important. If you go in and they say there's nothing wrong with you, you haven't wasted your time. It's because it's good. Keep probably doing the same things you are doing, or they may be giving you pointers as to how you can reduce your weight back into the appropriate age, weight range, be it your cholesterol is at a certain point, they can help you bring it down and all that. So again, at this stage, we should all be able to have a GP, a family practitioner, some physician who will just be seen for various checkups. You tend to hear politicians, unfortunately, leaving the country for checkups, and those are some of what I call some of these folks just wicked, in the sense that they understand what that is, but they don't ensure that the general population, gets to have the same opportunities to be able to have physicals done. Hopefully, and again, I haven't been up to date with what the NHIS does or what it covers and does not cover. Somebody can enlighten us as we do our discussion. Hopefully these things cover just general checkups, so that everyone will be able to do these things and keep ourselves in shape. So basically, when you do have chronic kidney disease, again, I've put in there a lot of symptoms. Some folks will listen and say, but then when you have pneumonia, for instance, you can be short of breath, as even you have kidney disease. So a lot of these things are non-specific symptoms, what I'll call them, but they are things that you can have with chronic kidney disease. I'm not saying that these things are specific to chronic kidney disease. When you're short of breath, it may be because your kidneys are not emptying well, you're not urinating well, you're going to be developing what we call edema or swelling, not just in your legs. So that is what the peripheral is about, but around your lungs and things. It will make you short of breath, and these are some of the problems that you run into. Frothy urine, again, it's neither here nor there. It doesn't mean that when you pee and you see bubbles, you should be scared that you develop kidney disease, but it's basically a sign of having what we call proteinuria, or protein in your urine, where your urine becomes frothy looking and things like that. So hematuria is basically blood in your urine. Again, it can be a pointer to chronic kidney disease. The point I'm driving to, or I'm driving at, is basically that a lot of these things are so non-specific that just following these symptoms will not be helpful in itself, but it's just things that as a physician trying to talk about a disease, I have to let you know what some symptoms are. But again, unfortunately, a lot of these things are very non-specific. I've put in there polyuria, which is excessive urination, nocturia, excessive nighttime urination, oliguria, reduced amount of urine production. Of all these three, the most specific one would be oliguria. You know, when, again, sometimes patients come, we say, oh, have you found yourself urinating less? They will look at you like, you know, are you crazy? Some don't pay attention, you know. Am I peeing less? Am I peeing more? You know, we just go in. If you want to pee, you pee. But it's a very important symptom. You know, maybe you walk around and you realize that, man, the whole day I've just peed once, or I've just peed little. You know, these are things that you shouldn't just take for granted. But some people can go the whole day and not pee. You know, again, we tend to do the usual thing, hydrate yourself, but keep in mind that something could be wrong. Excuse me. So I'll go to the next slide. These are other general symptoms, and what we call uremia. Uremia, U-R-E-M-I-A, which is up there, is basically a state where, as you can see from the word, it's quite similar, or it comes from the word urea, which is a very common waste product that we make. Is one of the reasons why our urine may change color, may be yellow and things like that. And if you're not peeing, this builds up so much in your body that sometimes people develop some sort of flaky appearance on the skin. It's not a common thing. It's not a common thing, but my son just brought me water. He thought I might be developing chronic kidney disease. It's not a common thing that you see, but when you see that, it's really late, big time. I remember in medical school, one of our professors had to call all of us from the clinic to come and see somebody who had come in Kolebu with, you know, this flaky, frothy skin, where you can basically see on a black skin a lot of white spots. It's just end game, you know, for kidney disease, where you've built up so much urea that, you know, it starts manifesting like that on your skin. But when you have uremia, you can have a lot of all these things that I've listed there: sleep disturbance, fatigue, cognitive changes, meaning not thinking straight, being confused, and things like that. You know, loss of appetite, you know, nausea, meaning feeling like throwing up or vomiting. Vomiting is all hiccups. Peripheral neuropathy, meaning having cramps and things in your legs. Again, some of these things will manifest in other illnesses, so they are not just specific to kidney disease, but this is what uremia can present us. So next slide. Management, basically, I talked about prompt consultation with and referral to a nephrologist, especially when your GFR is, you know, less than, when your GFR is less than 30. You know, we talked about hypertension management. Again, extremely important that you keep your blood pressure in check. And I put that management not because I want to sound like one of our business people, but it's what it is. We manage hypertension. Never take blood pressure medications and at the end of the month say, Medronasa, my blood pressure, my pressure, or I've stopped taking my medicine. You don't talk to your physician, you just stop, you know, you don't check your blood pressure at home, and you feel like because the medication is done, that is what it is. Again, in Ghana, you have to call your physician, let them know your medication is finished. I'm not sure whether, you know, our pharmacists on the call can probably enlighten us whether we are, you know, keeping good records of patients and having refill orders and things like that. Sometimes you can be given a medication, you can be given 1 or 2 refills and all. And, you know, the pharmacist shops will sometimes call you and say, you know, in calculating when you picked up your medication, we feel like it's time to pick up your next, you know, bottle. So come in and get your refill and things like that. So hypertension is managed. You can have your blood pressure better by doing certain things like improving your diet, reducing your weight, and things like that. Your physician will work with you. After a consecutive period of normal blood pressures, we can start cutting down on your blood pressure pills and say, if you're taking 2 or 3, let's get you down to 2, let's get you down to 1, see how you do, still keep monitoring. If things are looking fine, at some point you may be able to come off your medication. So that lifestyle change alone can lead to you basically not needing to take your blood pressure pills. But these are not decisions you should be taking by yourself. Sometimes you may feel lightheaded or dizzy when you take your medication. It may well be that either you've done things right and your blood pressure is better such that you don't need your blood pressure pills, or that for whatever reason your dose may be too high at that time again. And so you talk to your physician, they'll cut down on the dose and things like that and all that. Unfortunately, I'll use my own family's experience. My own mother visited, and I went to the pharmacy shop, and a medication called losartan she was taking in Ghana, she was taking about a 50 milligram dose. I got her the same dose yet because that's her dose. And, she was not with me, with my sister. We'll wake up every morning feeling dizzy and things like that. And, her blood pressure will be so low. We're like, what is going on? I just said, well, cut down on the dose and let's see. For whatever reason, the 50 milligram dose she was taking in Ghana was perhaps not exactly 50 milligrams. When we gave her the same 50 milligrams here, it was too high of a dose for her. So things change again, pharmaceutical companies change, medications change. Sometimes a generic form of a pill could be different from a trade form of it and things like that. So there are little aberrations here with some of these things. But again, do all these things in consultation with your physician. Lipid management, yes, there's a typo there, but it's management. Lipid management is basically also watching your cholesterol levels and things like that. Some of these things, if you don't manage your cholesterol well and all, it just goes hand in hand with, what we call metabolic syndrome in terms of hypertension, cholesterol management, diabetes. They all go hand in hand. They are all bad friends who work together and just make your life terrible. So controlling your lipids and all play a role in improving your kidney function. Again, we talked about diabetes. Extremely important that if you're diabetic, you check your blood sugar, you stay on top of your medications, you keep things in check. And like I put the intervention to slow down the kidney function, mostly per recommendation of the kidney specialist. There are medications that they can use to basically improve your kidney function such that it does not accelerate to an end stage level like a stage 5 where you need dialysis. And monitoring, monitoring is important. So the ultimate care, if unfortunately everything is done but you don't improve, is what we call dialysis, where you will need to have, and I'll talk about that briefly, in the subsequent slides. And it's basically a process of cleansing your blood, and it's done in 2 main forms. Next slide. This is what we call hemodialysis. This is an old machine, but it just brings the point out. But it's just a scheme of a patient lies down, you connect 2 tubes to them. One, as you see, there's a green line pointing to them, another a purple. The purple is basically getting the blood away from the patient. It goes into this machine, it gets cleaned out, it goes through this dialyzer, it picks up all the various toxins from the body and then disperses it, and then it sends back the clean blood into your system. So this is basically a kidneys filtration system outside your body working for you. Hemodialysis is usually recommended to be done about 3 times per week. It's typically done at the dialysis center. So you can imagine, hence the importance of kidney disease. You do your day-to-day work. You can imagine spending of your days in the week 3 times. It's like over here, it's like Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday kind of regimen. You spend all this time. If you cannot work away from your office, you can imagine how much of a toll this will happen. This will be on your, financial day-to-day life in terms of you being able to provide for your family and things like that. So, it's an unfortunate kind of situation, but again, this is better than not having a device like this to take care of conditions like this, because without good functioning kidneys, basically the end result is death. So hemodialysis is one form. Another form is what we call peritoneal dialysis. Again, so just next slide is just to show you what a typical dialysis center looks like. So you saw that just simple diagram. You can look at these machines. So one goes into a dialysis center. You sit down in these comfortable appearing chairs. There are stools. You can raise your leg up, feet up, be comfortable. A lot of patients fall asleep during dialysis and things. They sit by these machines. It runs for 3 to 4 hours. You know, not just cleaning their blood, but also taking up excessive volume, which is the urine that you haven't been able to produce, which has built up in your blood or in your system. You know, it filters it and then takes out the volume. So some go and then we get to take about, you can picture this, between about 3 liters, 4 liters of, you know, volume out of them, because this is done every time you go in, 3 times a week. This is how much volume is kept in there. You know, we take it for granted what our normal bodies do, how much we pee out and things like that. So they sit there, get this done over about 3 or 4 hours before, you know, they get back home. You know, most dialysis centers are daytime operating, so it's not like a case where you think, oh, I can go to work and after work I go. This is also their work, so they also have to go home. So it's working hours. So again, if you cannot if you can bring your laptop in, work from home kind of situation, this can work for you. But if you do some other job where you have to be there, this will be less hours for you. So this can be these are some of the things, you know, which can affect your life so much that you have to do your best to prevent yourself from getting into a situation like this. So next slide is also the peritoneal dialysis. This is the best, less gruesome picture that I could find, but it's a cross section of our body. Peritoneal dialysis is basically using your own body's kind of filtration system. So we talk about the peritoneal, it comes from the word peritoneum, which is basically the potential empty space within our abdomen. When we talk about abdomen, you know, folks who say stomach, you know, stomach is an organ. It's a specific organ within your abdomen. Within your abdomen, you have your intestines, you have your liver, your, you know, small intestines, your large intestines, and things like that. When all these things are there, that potential space is what we call the peritoneum. And there's a lining around the peritoneum, which is basically a membrane. It's a body's membrane that, again, God created within the peritoneum. And it basically works as a semi-permeable membrane. Or if you think about osmosis in school, you know, it's a membrane in there. So we utilize that to get rid of toxins and excessive fluid from patients' bodies. So basically, as you see there, and I'll show some pictures of it as we go along, there's a tube that is basically planted into your peritoneum. This peritoneal space, it just lies there. The tube comes out of your abdomen. It lays there. After its use, you can cap it and it stays there. You put your clothes over it. Nobody will even know that you have it. And then you fill up. This is the most, you know, or rather the more convenient form of managing dialysis, but perhaps it works for some people, it doesn't. You can imagine a tube always hanging out there sometimes, you know, infections and all kinds of things, you know. I'll say a greater number of patients do use hemodialysis, which is the first one I showed. Others use this peritoneal dialysis, where basically you fill your peritoneum with what we call the dialysate, or the solution that goes in there mostly at a higher concentration than your blood. So again, by osmosis, water flows from water is attracted to a higher concentrated fluid. So with a higher concentration, it sucks up the excessive water in your body into it, and then it flows out into the drainage bag that you see there. The convenience of this is that you can do this in your own home. You can do this at night, where you fill your peritoneum with this just before you go to sleep. You know, it gets your peritoneum, your abdomen enlarged, and then it stays there. It does its work as you're sleeping and things like that. By morning, you open it and then it flows out. And then it flows. Some people will kind of say, oh, my catheter is not flowing so well. For whatever reason, it may be clogged. Or when I feel, I become uncomfortable, the flow doesn't go in so well. So again, various things happen where this doesn't work so well. Where with the blood situation, it connects to the blood, it definitely works there. The main thing is that your connectors to your vessel, what we call a fistula, again, which I'll talk about just briefly, should be working fine, and then you can get going with it. But then it takes you away from work and all that. Next slide is just a dialysis preparation. So this is what we prepare in terms of developing what we call vascular access or a fistula. If your nephrologist is working with you and they can see that your disease is progressive, they can time that, man, in about 6 months, you're probably going to need dialysis. So this is the safest way and the healthiest way, in the sense that it uses your own body's vessels. We create what we call a fistula. They'll take you to a specialist called a vascular surgeon, or basically a general surgeon who specializes in doing this can also do it too, where they basically create an abnormal, or rather a less natural connection between your arteries and veins, typically in your arm. And as they do this connection, as you can imagine, this is a new surgery. You need time for it to heal. So it takes about 6 months for it to be fully healed, where all that a dialysis nurse will do, and there are nurses who specialize in this, will just connect. They have their two main needles. They'll connect one to your artery side of your what we call a fistula, which is the connection they've created, or your vein side of it, connected to the machine. The blood flows in, and this same blood will go to your heart. So the dialysis machine becomes part of your vessels at that time that is working. So one side is the venous system, one side is the arterial system. You know, the veins will go, what's it called? Flow from your heart to your body. So it brings it in, flow towards your heart. The artery flows away from your heart. It goes into the machine, gets cleaned out through the veins, it gets back in. So again, this is why follow-up is important. When you're working with somebody and they know that this is happening, they can prepare you for what is coming. It's unfortunate, but if you get this done in good time, it gives you a better dialysis experience. Some people show up and goodness, they are at stage 5 already. We try to fix them with whatever we can do. We never get any resolution of their. At that time, it will seem like an acute problem, because if you remember, I talked about the 3 months. Because we've just seen here, we are doing this. We call it an acute problem initially, until if it doesn't improve, then it becomes chronic. And at that time, you can need dialysis. At that time, you can still have this done, but it will not be ready to be used until 6 months later. So we put in temporary lines, what we call temporary dialysis catheters. You can go home with it. Sometimes it can become what we call a permacath, or a permanent catheter. That can stay a bit longer than a temporary one, until your fistula, what we call, matures. Your fistula matures, and you can go back to this. Fistulas also have their own problems, as you can imagine. Again, in as much as they are not like the peritoneal dialysis where the catheter hangs out of your body, every day the nurse goes in to clean. So all these sterile processes have to happen to prevent infections from being introduced. Some people will come right from dialysis and say, while I was on dialysis, I developed fevers, I developed chills. Unfortunately, at that time, you may have developed an infection where bacteria could be in your blood already. So we tend to check your blood, and we might see bacteria growing, and that's a different topic in itself. But then you may have what we call sepsis, or the beginnings of it, where we treat you with antibiotics and things like that. So they all have their problems, but again, creation of fistulas are better than having catheters exposed to the environment. Next example picture is, so this is not the clearest again. Our colleague Mamea thought the picture I was using was too gruesome or whatever, so she said you have to find a different picture. So this may be, I just try to blow this up a bit, so it's not the clearest, but there is a catheter there, as you can see. It's like a loop kind of thing pointing out from the patient's abdominal wall, and this is what the peritoneal dialysis catheter looks like. And this can be put in, again, shorter than the hemodialysis, just a tube being put in. It can be put in, and it forms a natural track around it. The body heals by forming a track around it. So that is why we give it about 2 weeks before you start using it for dialysis. It stays there. You can fold it nicely, put your shirt over it. Nobody will even know you have it. But basically, that's how the peritoneal dialysis catheter looks like. Next thing is basically just a few words on kidney transplant. For every patient who gets to a stage 5 kidney disease, you know, it's just right practice for transplant to be talked about. Selecting patients for transplant is a very detailed process. A lot of patients, for various reasons, will not be deemed as qualified participants to receive a kidney. But you know, you can imagine this is somebody, again, I said you can live off one kidney. That is why you hear a lot about people donating kidneys and things like that. When one donates a kidney, the transplant surgeon can transplant it. And most of the time, it's not put at where the kidneys are supposed to be. You can always feel a transplanted kidney on the abdominal wall. Somebody, they always know where their kidney is. So when they point out to you and you examine the abdomen, you can feel the kidney there. So they put this transplanted kidney there, and it basically takes over, you know, your bodies. They connect these ureters to it, and, you know, it takes over the filtration process. Sorry. It takes over the filtration process of your body, where people can have this and get back to regular life. You don't need dialysis anymore. You know, at that time, hopefully you have done things right in terms of what led to you having a kidney disease. You've controlled your diabetes better, your blood pressure is better controlled, all these other things you've worked on. And with that, you can have a normal life, and whoever the donor was can also live off their one kidney. So transplantation is something that is appropriate to, you know, talk to your physician about when you get to that stage. And family members commonly may be donors, but not all family members may be a match. You can have a stranger being a donor, things like that. So that's just something to also know. Next slide. So prognosis, basically, if nothing is done, prognosis is basically a term for, how do I put it? What other word can I use to break it up? But basically a term to describe the effect of disease on your body over time, what it can do to you if nothing is done about it. Or in some cases, no treatment can be offered. And with that, you know, the disease will run its course and will lead to problems. So mortality is what we call, is a term we use that basically talks about death in kidney patients, chronic kidney patients, regardless of age, sex, hypertension status. It's increased if you have chronic disease. If you have chronic kidney disease, your mortality, basically, if you were to live to 70 and develop chronic kidney disease at age 50 or whatever, your lifespan is certainly going to be reduced regardless. When you're going for surgery and you have chronic kidney disease, your chances of not doing well at surgery goes up compared to somebody who doesn't have it. When you have chronic kidney disease, you can develop, and that's the one thing that also kills a lot of kidney patients, cardiovascular disease, or basically heart disease. They can have heart attacks. They can have heart attacks and develop heart failure, all kinds of things, and basically other factors, which again, I'll not bore you, but these are the big things to know. So living with chronic kidney disease is, you know, a problem in itself. Prevention. So I talked about a lot of this before, basically controlling your hypertension, your diabetes, reducing obesity, reducing some infections, which again, I didn't delve so much into infectious problems, but there are certain infections that can lead to increased kidney disease and things. Good old malaria is one of them. Again, malaria is an extremely bad illness. We get it so much that we take it for granted, but malaria is not, you know, the best illness, and hopefully they can set up, and if they say there's going to be a vaccine in truth, you know, it might be helpful in terms of our way out of malaria. But some bacterial infections like streptococcus bacterial infections can lead to kidney disease as well. I talked about avoiding unnecessary use of what we call nephrotoxic. So nephrotoxic is basically anything you put in your body that will be toxic to your kidneys. That is the term we use for that. But the one common group of medications are the NSAIDs that I talked about, i.e. the ibuprofen or brufen and all these other NSAIDs. You know, avoid unnecessary use of them. And early recognition and management, again, is extremely, extremely important. So, you know, this is something that we have to keep very much at the, you know, top of our daily lives. So screening, we talked about that again. This is basically visiting your physician, checking out your body, whether there's something going on and you don't know of, you know. Certain high-risk patient, again, the elderly, you know, the older you are, the more likely you develop problems, diabetes, hypertension, you know, all these things that I mentioned along the way. It's important that you get regular testing and all that. It may sound ironic, but my American College of Physicians do recommend against screening, you know, people for chronic kidney disease when they are asymptomatic. Again, so then you see the irony, it's neither here nor there. The bottom line is that you just need to have your recommended, you know, primary care visits. A lot of the time, anytime you hear the word screening in medicine, you have to think money, because Screening is basically doing things on people who are presumably healthy, finding out problems that may not show up. So it costs money. So it takes a long while for one to just come out with a screening guideline, which will make sense, which will make financial sense. So that is why they are not so eager to say everybody should just go in tomorrow. Everybody on this call should go in tomorrow and tell their physician that I want you to check me for chronic kidney disease. If you do your regular checkups, the timing alone will be in itself good enough to pick up any illnesses if you do have it. And the American Heart Association also does the same, but they recommend screening for patients with cardiovascular disease, because if you have kidney disease in conjunction with cardiovascular, meaning heart disease and vascular disease in itself, that can certainly reduce your lifespan. This is a statement I like to use for my patients, so I'm owning it. You know, when patients come in, you'd be surprised here with all these resources, somebody will come in at age 65. I don't like doctors, I don't see doctors and things like that. I just ask them one question: if they have a vehicle or vehicles, and they say yes. And I said, but you take it in for oil changes and all that. And they say yes, right? They're like, where is this guy going with this? I said, well, if you do these things on your vehicles and you do oil changes on them, you should see your body as the same way. Your body also needs an oil change. Your body also needs checkups. So you have to, treat your body the same way. So a few of them will shake their head. Others will say, well, I get it, and things like that. So it's just a favorite statement that I tell patients who don't tend to have physicians or don't care to follow up with their doctors. I talked about the World Kidney Day in March this year. The theme was living well with kidney disease, and there are some nice slides. If your phones store our conversations on our WhatsApp, so these slides that he put up, I can think when I look back, the date was specifically March 7th this year. It's when he uploaded these slides, and they have good information on what is going on with the Ghana Kidney Foundation and the things that they are doing in terms of helping us manage kidney disease back home in Ghana. So that was enlightening, and it was for public consumption. So you can go back and then look at those slides. I missed the other jokes on our pages. Economic burden of kidney disease. So I talked about that, the importance of it, missing work days, inability to provide for your family because you're not making a good income, the exorbitant cost of dialysis. Fortunately and unfortunately, in certain places, these things are covered by your insurance. In other places, it's not. I talked to a colleague of mine who works as a nephrologist in Kolebu, and he was able to give me his exact figures. For every dialysis run, I think he mentioned that in Kolebu, it costs 325 cedis. You may think it's not a big amount of money, but you do this 3 times a week, 325 cedis times 3 for the rest of your life. You can imagine what a life-changing cost that will be. And that is in Kolebu. In other places, he says, obviously there have been some private people, and it's good business for other folks setting up dialysis centers and things like that. They charge between 350 and 500 cedis per session. So we're talking 350 or 500 times 3, which is 1,500. Okay, that's just 1 week, times 4, which is 6,000, times 12. We're talking 612, what, 72. So 72,000 a year just to stay alive. So in Ghana, I think my next slide will say it. Dr. Jomwa Edu in Kolebu Teaching Hospital, I picked this up from these slides that I said, so you talked about. He says, kidney disease is unfortunately a lethal condition in Ghana. It shouldn't be so. This is my last slide. It shouldn't be so, but it is because people cannot afford it. And back home, people develop this, and we just start shaking our heads as medical students, as house officers, as physicians, because we know this is a big time thing. You hear on the radio, people are raising funds. For how long can you raise funds to treat this kind of condition, for the rest of your life? So the stakeholders on the call and all these other people, we should be able to see how much with our influences back home, how much we can push for NHIS to cover some of these things. But again, prevention is extremely better than cure, where if we work so hard on preventing these things, we can imagine the economic burden that can be off us as Ghanaians. And again, 13% of Ghanaians having chronic kidney disease. By estimates of Ghana's population, which I checked last night, we are right about what, I may not remember again, 34 million and whatnot. If you bring it down, we're talking about over 4.1 million Ghanaians having chronic kidney disease. This is a lot of people. So you can imagine people who will be dying unnecessary deaths at a young age because they're not able to get regular care for their chronic kidney disease or end-stage kidney disease where they may need dialysis. So this is the end of my little talk, and I'm open for questions. Thank you for listening.
Thank you very much, Norris. I'll start, and I think I have a question for you. You talked about high blood pressure and diabetes and all those other things probably causing this. What about those who don't drink water? Has it got anything to do with any of these things?
It has, and that is a poor habit that we should all seem to, we should all try to clear up. Again, in as much as he brought me the water, I haven't even taken a sip yet, but I was trying to get through my speech. But water is, or my talk, water is very important. Again, when you live in a cold area like I do, again, I see patients coming all the time, old women especially, passing out at church, commonly, and they come in and they are so dried, you're not hydrating. You see them, you check their kidney function and it's abnormal. It's quite easy to fix. At that time, it's what we call an acute stage. It used to be called acute kidney failure or acute renal failure. We call it the kidney, foundation want to call acute kidney injury. And with quick hydration, most people tend to recover. So, good point. Hydration is extremely important, as you can imagine. If you have a good, easy volume for the glomerulus to filtrate, it works better than having thick, concentrated volume where it's difficult for filtration to happen. So, hydration is extremely important. Unless you have some conditions where you're not able to hydrate, anywhere from 2 to 3 liters of water should be what we should be shooting for in a day. Or if you deal with ounces, at least 60 ounces of water is what we should be shooting for in a day. And I say water, I mean water, not any other fluid, not coffee, not any other thing, but water. Coffee is basically a diuretic. It will rather technically dehydrate you, make you pee. If you do it, if you drink a lot of caffeine, you can know yourself how much you end up urinating. So I'm talking about good old water. Thanks for the question.
I think Peter Kim has a question for you.
All right.
Mine is not really a question, just to add to what you said, and I think a disclaimer. I have had chronic. I was diagnosed with CDK about 12 years ago. So I joined this research group, and it took a whole history of me. What I found was, and I think this information is more for our children rather than us, or maybe you need it as well. When I was doing the research, they concentrated on our time in primary and secondary school, particularly in secondary school, and our activities in secondary school. So that was what a lot of my concentration was, the history. And at the end of it, what they told me was my activity levels and the amount of water I was drinking, the weather condition in Ghana. Mm-hmm. And what I do remember is in Achimota School, we leave the boarding house without probably drinking water. We will go to the dining hall, we may not even drink water. Mm-hmm. And we will walk throughout the day. There wasn't any water available that we could drink.
No water fountains, nowhere.
No. And we will go to dining hall. Probably we can walk a whole day with very little fluid intake, especially the boys. I don't know about the girls.
About athletes too. Mm-hmm.
Yeah, and then the like of me will run to the games field almost every day. And there was nothing there. Nobody brought us water there. So they actually pinned my injury. That was the period that I might have developed acute. kidney injuries, and that wasn't looked at. And of course, I grew with it. And Ghana, we have people. Some people are just proud to say, "Me, I don't like drinking water." You know, they say it with pride. And so, based on that, they identify where things are. 12 years ago, I was stage 2. I've now got to stage 3. I keep going between stage 3 and stage 2. So 59, 58, then the GFR will come to 60, 61. For the past, I think the last 2 years, it has remained around 59, 58. So I get to stage 3 now. So we need to be fairly conscious, especially to our children, the need to get them to be drinking as much water as they can, especially those in Ghana where the weather is very, very hot. I think that's just my contribution that I wanted to add to this.
And let me add something to it. So with what Peterkin said, is an extremely typical situation where I pray that, you know, things remain the same way. I was, when you said I've been going between, I was praying that you were not going to tell me stage 4. Mentioning that is stage 2 and 3, that is an extremely ideal situation. God being good, you could remain in stage 2, 3 for the rest of your life, and you will not progress if you continue to do things the right way and all that. You know, when you feed your kidneys with the good things, and you do things right, you can remain in one stage, hence the term chronic, for the rest of your life. And it doesn't mean that as soon as you develop it, you're definitely going to end up on dialysis. That's not what it means. You could remain in that stage for the rest of your life, and as you continue to do the right thing. So that's just what I wanted to add.
Yeah, great. Yeah.
Norris, there's a question in the chat. If you
Okay.
From Teresa.
Just a minute. I'm not a zoologist, so
If you want, you can stop sharing your.
All right.
Yeah.
Maybe let me do that. Okay. So I'm in the question area. Teresa says, do we need specific requests for screening, or screening is part of? Yes, good question. So it's an extremely simple test that we do. So Teresa, we don't need any specific request, but most yearly physicals will have you do generally, 2 or 3 broad groups of tests. One will be doing your complete blood count, where we'll be checking your hemoglobin level to see whether you develop some anemia, to see what your white count is, whether you develop some white count problems. So that's the one aspect. The other aspect will be checking your chemistries, where we'll be looking at your creatinine level, which will be used to calculate your GFR, which we talked about, the glomerular filtration rates. That is when they'll also be looking at things like your sodium, your potassium, your chloride levels, your bicarbonate levels, and your glucose. So when you fast and you go in and then they test your blood, they certainly check your kidney function as well. So any good yearly physical, these are one of the cheapest tests that you can do, will have you do these tests as well. So you don't need any specific request. Any good physical should have this test as part of the test that they will ask you to do. You're welcome.
So Norris, question. So you do your physical, they go in and, you get your results. The doctors can look at your results and think everything is normal. If it is, do you ask to find out about your kidney number, or because the doctor says it's normal, you just take it for face value? Is it something that as patients, when we go in, we should still ask that, could you tell me a little bit more about where my kidney number is? I don't even call it kidney number, but in that
GFR. Yeah. So good question. Again, that is what this whole talk is about, us being empowered. When you ask the doctor that question, he will look at you twice and say, hey, patient, so so this is because you've armed yourself with this information. You know exactly what you're asking. They'll give you these numbers, and then even if it's whatever it is, again, so that is, again, thank you very much for asking this question. These are some of the things where patients will show up and I tell them, oh, did you know you have some chronic kidney disease? And they look at you and they are surprised because they may have been at a stage 2, at a low stage 3, 3A for 5 years in a row, physical. And because the doctor is in a rush in looking at other patients, they never tend to talk about these numbers. So they do not know. And the reason why, for myself as an internist, a hospitalist, meaning I just work in the hospital, I don't see day-to-day patients in the clinic. The reason why I always want them to know is that if I walk into your room and I'm telling you that you have an acute aspect of your chronic kidney disease, I don't want you to look at me funny, because I expect that you know that it's not just hypertension and diabetes that you have, but then you also have chronic kidney disease. So if I tell you that you have an acuity in your kidney function, don't wait to walk out of the hospital thinking that that number is going to be normal. It's going to be brought back to your baseline, what we call it, back to your previous number. So for me, when I get you to that number, I feel like I've done my job. I'm not coming to perform miracles to get you back to 90 and above or a normal number. So, just like a diabetic or should know what their A1C is, somebody with chronic kidney disease should know what their GFR is, even if you don't have it and you want to be, prim pro and know exactly what you want to know. There's nothing wrong with asking for your GFR and knowing. I see Kofi Dodu has a question.
Thanks, Norris. Very helpful discussion. I put a question in regards to the black race. Does it have anything to do with diet? The things likely to Black Americans, Africans, the amount of protein or lack of food. And then, secondly, are there things that generally, apart from drinking water, that help, to have better kidney function? And it was interesting you pointed out that physicians should have discussions about all these numbers. I mean, I have sleepless nights anytime I have to go and do my annual counts. I'm not sure what will be found and that sort of thing. So it would be helpful to give some encouraging words, especially for us all over 40, on how to approach these annual physical, what kind of mindset will help us, just relax and go through knowing that whatever you find is for the better and not the worse.
Great, good questions. So for the blood race issue, again, it's not so well known. Again, I did not go so much into that with part of my talk, but there's a gene that they found which we express, which may put us at a higher risk, which may put us at a higher risk of developing kidney disease, or it may just be for the fact that in terms of those here with the ancestors and gene expression can sometimes happen with environmental factors over time. So with most of us living in warm Africa and things, who knows if over time we did develop this gene, which was to deal with the fact that our hot climates are putting our kidneys under a higher stress than somebody who grew up in Norway or whose ancestors were in Norway. So that's just what I have to say about that. But at the same time, socioeconomic factors in terms of lower socioeconomic status generally, if you look at the United States specifically, for a lot of Blacks who are in the South, who in a warmer climate, perhaps in a lower socioeconomic status, hence not eating well, developing a lot of associated illnesses like hypertension and diabetes, could have put them at a higher risk as well. So that will be my comment on, this question with regards to the Black race. Now, in terms of the better kidney function, not just drinking water. So again, the hydration is extremely important. There's nothing better that you can do for your kidneys other than, hydration. Extremely important, enhancing good filtration and all that. There are charts in certain rooms that you can go to, or in certain gyms that you go to where they say if you look at a specific color of your urine, it should tell you whether you are well hydrated or not. Overhydration is also not great. I mean, your urine should have some color to it. You know, that light yellow color is something that, you know, is ideal. You know, if your urine is so pale, it may well be that you could be overhydrated for some other reason. And the reason I bring that up is that, you know, certain conditions like what we call hyponatremia or low sodium states can lead to, you know, confusion and problems like that, loss of electrolytes. If you overhydrate yourself, you know, that can lead to that. You know, drinking excessive amounts of beer, you know, can lead to, beer is typically just a very low quality liquid. For all the gains that we gain from it, doing it excessively tend to increase your body volume unnecessarily. It can lead to these low sodium states. That is why every bar has a pee stop with it as well. You know, you tend to increase your volume and you tend to pee and all that. So it's the hydration is important, and just all the associated diseases, be it hypertension, diabetes, other things, are the things that you have to, you know, look to, you know, keep your kidneys in shape. I don't know if I answered your questions.
Yes, you did. I mean, the last thing to do is just the approach towards annual.
Oh, yes, I left that out. So again, it's all about the rapport you have with your physician. You know, it's unfortunate, I'll add, you know, these airs around us as some physicians that we carry is extremely unnecessary. You know, you should be able to have a good rapport with your patients. They are the reason why you are in work. You should be ready to talk to them about their healthcare. Sometimes you can politely, again, I'm talking from the physician aspect, you can politely let the patient know that we can talk about this particular issue today. The next time we'll talk about this and whatnot. But so as a patient too, sometimes they are constrained by time, such that you should be able to limit your questions to a certain line. If you say today, my concern is with my kidneys, and you want to just zone in on that, you can, you know, in a nice way say, you know, I've gotten to know about kidney function and what they call GFR, which is basically a marker of how well my kidneys are doing. Are you able to just tell me what my GFR is? And they should be able to tell you as long as they've ordered that test. So I don't think that should be a problem, but we should be empowered to discuss these things and all other aspects of our health with our physicians.
Thank you.
Yeah. Nanama.
Hi, very
Hi.
informative discussion. It's a refresher as well. I just wanted to throw a little bit light about what you said. So aside going to the our PCP or our general practitioners, we should also invest in monitors like the blood pressure monitor. So we should try to get that, because blood pressure, for example, as you mentioned, is a high risk for CKD.
Right.
But if you have the blood pressure monitor, at least you can be able to check your blood pressure in the comfort of your home.
Mm-hmm.
And I always empower my patients to monitor their pressure, because sometimes you go to the doctor's office, you are stressed going there. So obviously your blood pressure might go up.
Exactly.
And the doctor might add more medications. Like you said, your mother had losartan in Ghana, and the same strain, she came here and it was super high for her. So just to, as Motown group, let's try to invest in blood pressure monitor. We should invest in the glucometers, like diabetic supplies, be checking that in the comfort of our homes, because you might get the lab results and you're like, my blood pressure seems to be normal, but anytime I go to the doctor's office, it's high. And another typical thing that I've seen, like as a pharmacist, just checking some of my patients, let's say they're on lisinopril, and like some of these blood pressure medications also protects the kidneys. Yeah, exactly. So it's not just the being on a medication that you're like, oh, I'm going to take half of it today or half of it tomorrow. It prevents the kidney, the chronic kidney disease in future. But what I was trying to say is, if you are able to monitor these numbers and there's some discrepancy between the actual lab results, you can be able to find out what maybe there might be something going on that might be an underlying cause that the doctors might not detect. But if you have a log reading of your blood pressure, you are checking your glucose levels at home, and you know what these numbers mean, and you empower yourself, it just gives you more confidence to understand how you can treat yourself and make you feel better. I wanted to add something. Sometimes, as we age, you speak something and you forget. But anyway, let's just encourage each other. Yeah. So what I just reminded. So like I've been monitoring these patients, right? I try to do a 90-day supply on their medication. So every 90 days, 3 months, I call them, and they come back with their lab results. And those patients that have been adherent on taking their medications, I see a significant improvement in their health, because you might check their GFR and it might be, let's give an example, 80. And they come back and it might be 85 the next time in 6 months. So adherence to medication is something that you might not, let's say I'm not on blood pressure medication, but the fact that I am able to check it periodically at home, I tell myself that, okay, maybe I'm gaining weight here and there. And the last conversation we had with Evelyn, she talked about weight loss and weight gain, trying to lose weight and trying to make sure that we stay healthy by applying different type of techniques. But what Norris is saying, which coming from a pharmacist's view, is we are not getting younger, and our metabolic rate is also slowing down. So we might, laugh about it or play about it, but when the reality hits and you have some type of crisis and you're like, oh my goodness, they've told me maybe I have 3 more years to live, but we could have prevented it if we had taken some of these little, advice here and there. So let's take whatever he said seriously and apply it to our lives, so that at the end of the day, we can, if there's a reunion, we can, join and just have a good conversation. But thank you, my sweet brother-in-law.
All right, yeah, Nanoma. So yeah, very good pointers. And again, just to add a little bit to what she said, she used the term log. That is extremely important, that, if you have high blood pressure, you keep a log of your blood pressure, because again, working in the hospitals, I tell patients, I hardly want to, adjust your blood pressure pills, because the whole hospital environment is an extremely stressful environment. Patients come in and you find an average, their blood pressure is being high. You go in and then the family member is pointing at their monitor next to them and say, but the blood pressure, and I said, oh, that's fine. I'm not too worried about that, because I know the patient is stressed. They're probably missing something at home. They probably want to go home, things like that. So checking things, that is what I call patient ownership. Owning up to your own health, checking things in your normal environment is the best thing you can ever do for yourself. It's the same with diabetes. Ideally, every diabetic needs to check, not to say these things are inexpensive, but you need to check your blood sugars before every meal and at bedtime. You keep a log of it. It helps your physician when you go in and they see that your numbers are different, be it your blood pressure, be it your blood sugar. They are able to, in a more informed way, change your medication. That one-time check in the hospital or in the clinic can sometimes be as useless as anything else, but they just have to do it because you're there. And patients will sometimes not, either take their medications right or do things right. They go in, their blood pressure is so high. What does a physician do? They give you more medications. You go in and then you take them, you run into trouble. Patients show up in the hospital, I look at their medication and I said, there's absolutely no way I'm going to put you on this medication. I'm going to be conservative and see what your blood pressure does. And you realize that their blood pressure stays normal. So if I were to put them on the medications that they claim they are supposed to be on, we'll be in crisis where their blood pressure will be extremely low and things like that. So owning up to your health, again, doctors, we are human beings like all of us. We're all mates in school. Going to medical school, they never put any hood on my head to change me from a normal human being to a supernormal human being. Talk to us, talk to your doctors, be empowered to talk to your doctors. There's absolutely nothing wrong with asking them questions. You should start questioning that doctor if you have an option, whether this is somebody you want to be with. If you ask them a simple question and they become quote unquote angry. Unfortunately, sometimes you don't have any options because of availability of physicians and all that. But every doctor has to be able to answer questions if you have them, if they can.
Norris, you've left Ghana for a long time. These doctors don't answer questions in Ghana.
I know. Mamia, I see you have a question.
Yes, I wanted to add that the NSAIDs that you talked about, like the ibuprofen and Motrins, those ones are very serious. I can attest to that. I have my own example I can share. I had, right around my book launch, I experienced toothache. So for like maybe 2 weeks, I had severe toothache. They gave me different things to put on and try to figure out what was causing my tooth. Apparently, I had a crack in my tooth, so I had to go through surgery. So the pain from the toothache, I started taking Tylenol was not cutting it. I take Tylenol within 4 hours. I felt the sharp pain again.
Paracetamol, yes.
Paracetamol, right. So I felt the sharp pain again, and I told Norris, I don't get any relief with Tylenol or paracetamol. I want to take ibuprofen. And it was so painful that 2 ibuprofen tablets wasn't going to cut it. So I started taking 3, and it was nice. There was no pain. I kept taking the ibuprofen, and that was my go-to medication in my bag. So around that time,
treating them like vitamins.
You know what? Let me just tell my issue here. So I went to do my annual checkup, and at the annual checkup, when the results came, my doctor said, "You have some." What was that number? It's supposed to be like
your creatinine went up.
Yes,
your creatinine went up. Your GFR, of course, a little bit down, but she was basically. I'll take it from here. She brought it up herself, so I'll empower myself and talk about it. So basically, she developed some form of acute kidney injury, and being me, of course, we were extremely concerned. I started putting her through drinking more water, whether you like it or not. I took away all her Motrin pills, of course. I can't take NSAIDs because, their sister medication is aspirin. When I take it, I do develop some. Again, we are one big family, so everyone is different. If you want to talk about your own medical issues, it's up to you. Nobody is under any obligation to do that. But when I take it, I get some chest tightness, which is what some of these NSAIDs can do. So, I got it from my mom. She's tried other NSAIDs. It works for her. I recently had this severe back pain. I was not going to take any NSAID. I dealt with my Tylenol or paracetamol, whether it goes or not. So I'm afraid of NSAIDs. Basically, that's me. And she took them. She developed this problem with hydration and all that. Subsequent checks, God willing, her creatinine came down to normal. Her GFR is normal. So this is a clear example. Yep. I did not, want to bring it up again. She's brought it up herself, but that's a typical example of NSAIDs again. Seemingly, they are over the counter. You can just pick them, and just start taking them, but don't take them lightly. They'll talk about the ulcers and things like that, but they can also affect your kidney function.
Yep. And I had surgery. I took the cracked tooth out, and the pain went down. So the pain was from the cracked tooth. But, I never thought that I would take ibuprofen and I will have an issue, because ibuprofen to me, I felt was safe. It was maybe safer, faster, right? And Tylenol is every 3, or paracetamol is every 6 hours. Ibuprofen was 8. So at least I could buy time with the pain. But ever since then, I don't touch ibuprofen at all, because to me, if I have a headache and I have extreme pain, I would do Tylenol and try to manage it. But I stay away from ibuprofen. Look, I had ibuprofen in my bag, and that was my go-to medicine, and I don't have it anymore. So lessons learned. Ibuprofen is not your friend when you take it consistently. And I started drinking water. So the doctor would say, "Oh, you're slightly dehydrated. You should drink water." I said, "I'm drinking water," but just an FYI, let's not take things for granted. We're not 20 anymore. You know, our systems are broken, to say the least. You know, so let's be mindful and careful. You know, we all want to age gracefully, but we shouldn't let unnecessary, you know, hiccups, you know, slow us down. So for me, I'm staying away from, you know, NSAIDs, no ibuprofen for me for probably ever. So yes.
And let me just add one thing. Again, so I mentioned that I'm scared of it for various reasons. Everyone is different. I'm not in any way, shape, or form saying that absolutely don't take this if your doctor prescribes it. But most physicians, when they put you on this medication, will give a timeline. It can be time dependent or duration dependent. It can be dose dependent. They will never put you on this medication indefinitely, again, unless for other reasons. But that is why you have to monitor and follow up with your physician, and you have to keep checking things. If they start seeing problems, they're going to back off and things like that. So I'm not in any way saying that NSAIDs are an absolute no, but that's not the message I want us to take from here. Christopher, I think you have a question.
Yes. If I remember correctly, Dr. Felix Boachiajiman, when he did his talk on the vaccines, also talked about people who take vitamin supplements.
Yes.
And how that affects your kidneys, as well as people who perhaps get these natural seeds and stuff. What are your thoughts on those things that we blend?
So it's the same idea. We all do it. You know, one picture that I had in my slide that I took away, and funny enough, was this hibiscus drink that we all drink. This Sobolo drink became very popular during the COVID and all that. Again, everything is under moderation. So I put this picture in, you know, Mamiya did one. I had it in my glass at one point. She garnished it with some pineapple slice. I was just trying to make my slide, you know, funny, and I put it in, but I took it out and all that. And I said, this is the most ironic picture I was going to put in, because these things will come up and I'm putting this in. I'm not condemning any of these drinks or anything like that. What Felix said about the vitamins and all, these are all these over-the-counter medications. Each person is different. We all have different genes. We express things differently. Again, if we don't take anything away from this discussion, it's about having a primary care physician, having ongoing monitoring, you know, where your doctor will take a history, will find out what is going on in your life, what may have changed. Have you started taking a different form of herbal product or a different form of vitamin? Maybe let's cut it out. Let's see how this goes with your kidneys and things like that. So again, this will not be to shame all other supplements and things, but the monitoring aspect of things will reveal whether something is a problem for you or not. So that will be my answer to that. Any other questions?
I just want to say there was one picture that Norris wanted to put in with the catheter stuff. I was like, no, don't do it. So I saved you all nightmares. Let me tell you that. That picture was.
I took your
You needed to be frightened enough to take more seriously.
What was the question?
Kofi, I didn't hear that. Oh, Edwin has a question.
Frightened that enough.
Yes.
Yeah, I guess maybe. So because there were a lot of scary questions, you can always, a lot of these were just by Google searches, so you can see what unfortunately people go through, but they are not the most pleasant of things. But some of us see it every day, and perhaps we get so-called used to it. But I know. So yeah, Edwin, you have a question.
You're muted, Edwin.
You are muted.
Edwin, you're muted.
Edwin, you're muted.
Can you hear me now?
Yes.
Sorry. Talking about ibuprofen, I wasn't part of the talk earlier. I just joined. So apart from kidney issues, have you got any other problems that I can give you, that ibuprofen?
So another common thing, which is on most bottles, if you take it on an empty stomach, you know, it can develop. You can develop inflammation or ulceration within your stomach and the beginning of your small intestine, your duodenum. So they can cause ulcers. So one thing that pharmaceutical companies have gone around this problem is they do coat these medications. You see some of them, they'll say they are coated. And you can even see enteric, they'll say EC. When you see EC after aspirin, it means enteric coated. So
Okay.
Aspirin EC is coated to be easy on your stomach, or you need to take it put in your stomach. So these are the two main issues with it. For NSAIDs in general as well, if you have, hopefully nobody has it yet and may not have it, but if you have things like heart failure and all that, it's not an appropriate medication to take, the NSAIDs in general.
Okay, all right.
And again, good old medical school of Google, you can Google some of these things yourself and also find out if you are concerned about anything apart from discussing with your physician, because you may not get to talk to your physician immediately. So take the good and bad. You know, we take the good and bad from Google, whichever one works for you.
All right, thank you.
Yeah.
Is that all? Anybody else has any questions for Norris? Any contributions? Anything else to say?
Norris, so CKD, a lot of the patients that I've seen, they explain concern about ED, erectile dysfunction. How, like, what is it the CKD that is causing that, or some other underlying condition?
So in terms of me saying that is causing it directly, perhaps not, but most of these patients, as you may know, will either have hypertension or diabetes. Mm-hmm. So they may have developed vascular disease from the hypertension or the diabetes, which again, like I said, when I said diabetes can affect you from head to toe, that's what I meant, head to toe and anything in between. So, you know, with vascular supply to, you know, the good old cherished organ for us guys, you know, if it's compromised and all that, it can produce erectile dysfunction. So they are probably, you know, when patients are ill, they, as you've met them, Nanama, you know, they pick up, they want to blame anything else and everything else other than certain things. So it's not directly the CKD, you know. Of course, a state of uremia, which would be the far end of, you know, CKD, can, you know, produce so many symptoms, but it is most likely the effect of their diabetes or their hypertension causing vascular disease and leading to their erectile dysfunction, not so much the kidney disease directly.
Gotcha. Thank you.
I mean, sadly, I mean, one of my friends in the States, I think he's on stage 5. Every night he has to do dialysis.
Peritoneal, I guess.
Yeah. Every night he has to do it. And this is, I suspect that most of the time we have grown up back home without drinking water, and we never took water seriously. And perhaps this is some of the problems that we've brought over as well. So thank you so much, Norris, for this talk.
Thank you for encouraging me to prepare it.
you really done everybody proud. So thank you so much. And if you've got any questions for Norris, feel free to reach out to him. I'll just stop there